Well, hi everyone, and welcome to the second installment of the Sports Science Institute Spotlight on Mental Health Action Plans. So in our last installment, we discussed the full spectrum of care and spent a bit of time on mental health screening tools, outlining some that are very specific, such as the Sports Mental Health Assessment Tool, or SMOT, and also briefly mentioning the Sports Mental Health Recognition Tool for non-clinicians as a way of helping to identify athletes who may be in mental health distress. Today, we're going to really be focusing on pathways of referring student athletes to licensed mental health providers and provide practical considerations for communicating and rehearsing both routine and emergency mental health care. And very pleased to welcome back our two guests from the previous session, Dr. Claudia Reardon, professor at the University of Wisconsin School of Medicine and Public Health in the Department of Psychiatry, and also co-chair of the first and to be coming up, the second International Olympic Committee consensus meeting on mental health care and elite athletes. And also Kim Terrell, Senior Associate Director of Athletic Medicine at University of Oregon, and also an exceptionally important participant in our Committee on Competitive Safeguards and Medical Aspects of Sports. So welcome back, Kim and Claudia. Thanks so much for being here with us. So in the last session, we talked about mental health best practice number 3, really the referral pathway. We spent a lot of time on screening, but let's get into the actual pathway of action plan. So what are some common components, considerations for a written, routine mental health action plan, taking into consideration things such as roles, responsibilities, referral pathways, coordination of care, and the like? Maybe let's start off on that.
I certainly think your question is a good one in terms of the real grassroots of getting into creating this plan. Identifying people's roles and responsibilities comes down to identifying first, what resources do you have available that can be part of your plan? Do you have a mental health provider who might be the point person or care coordinator for this program? And are there clear referral pathways that can be initiated by other providers, or should all referral pathways go through one single individual? I think there also needs to be very clear triage criteria. We can probably talk a little bit later about sort of a trauma-informed approach of how to triage individuals to determine where in the plan they need to be referred. Certainly looking into how is the plan communicated, and then also the decision tree documentation and that sort of thing.
I agree with everything you said, and really thinking through the specifics of who can make a referral and how does that happen. So how does an athlete themselves get, if they don't want to go to their team doctor or their coach or their athletic trainer, can they connect directly with a psychologist or with the psychiatrist or whoever it is, versus if a psychologist who works with athletics in the community wants to refer to the psychiatrist? How do they do that? Thinking about all of these very specific situations, I think, is helpful because they all come up on a regular basis for sure. And then absolutely agree with the importance of disseminating, advertising the existence of this plan so that all of the stakeholders know of its existence and how it operates. Practicing the plan, so rehearsing both in routine and emergent forms so that it doesn't come down to, oh no, I need to use this emergency plan in the moment. I have no idea, but you've actually practiced it before, just like you practice CPR scenarios or you practice use of an AED. We need to be practicing use of plans like this. And then finally, is there a mechanism built in for continuous quality improvement of the plan? So this is not a plan that should be stagnant. Once it's written on paper and the ink is dry, we're done, it's forever good. Of course not. Just like with any plan, fine-tuning it as more experiences accrue is important.
The two groups I was just thinking of that have come to me recently are academic support staff. They need to be included in this plan because often athletes will identify as struggling when they're in their offices, and they just need to know what that referral process looks like. And then coaches also really do want to be resources for student athletes who come to them and ask for help. So I think including those groups is important.
Yeah, I remember during the last session, we talked about having QR codes everywhere in ways that the athletes understand. So let's say, okay, the athletes understand how to make a referral, but let's talk just a little bit about the reluctant athlete. So the athlete who is maybe feeling depressed, anxious, having flashbacks, having doubts, but doesn't really want to reach out. How do we help develop, and what's the appropriateness of developing sort of a buddy system, student to student or coach to student, or, certainly people in the athletic staff? How do we get that worked out into routine referral as well?
I think there's many people who are trusted by these student athletes, and that circle of trust needs to also include the opportunity to help make that athlete feel safe and supported, and help them maybe consider a mental health referral, if not immediately, sort of in the future, providing them some just conversation around maybe what some of the limitations are. I always use analogies with physical injury because I think we're also comfortable with those. If somebody had an ankle that was swollen and they weren't performing well and they were limping at practice, I would take them aside and talk to them about getting their ankle treated and what we needed to do to get it stronger so that they could be at their best. And I think we can use those same analogies and conversations around mental health to try to help normalize and also just make students feel and see that it's a path forward for them to help themselves feel better.
Absolutely. The more we can demystify mental health so that people get familiar and comfortable with saying the words. If you never say the words depression, anxiety, suicide, it's such an anxiety-provoking thing for people. They're understandably scared, terrified of it. One of the things we've found that really has made a difference is mental health first aid training. Dr. Hainline, I think you mentioned this in the last segment, but this is really huge in terms of demystifying mental health. And here, we offer mental health first aid training here within athletics every 8 to 10 weeks, which is quite tremendous. We have dozens and dozens of coaches who've been certified. We have people across the spectrum of the athlete entourage. We have guest services representatives in our department certified. I mean, if you touch, interface with the athlete at all, we welcome and encourage you to become certified. And it's the kind of training that really does help demystify the language and get us all comfortable supporting athletes in this way.
Yeah, and for our audience, in case you missed it, that was our very first SSI Spotlight series. It was on mental health first aid at Ole Miss as an example. So check it out. Maybe let's just shift gears. You mentioned it briefly, Claudia, but getting into the granular aspects of a mental health emergency action plan, roles, responsibilities, emergency contact information, triage guidelines, de-escalation techniques. So how does that differ from the routine mental health care action plans that are written and rehearsed?
I think in a few ways it's different. One needs to clearly define what constitutes a mental health emergency because that is not obvious to everyone. So suicidal thoughts with a plan, homicidal thoughts, acute agitation or threatening behavior, acute sexual assault, violence on campus, incidents of racism, bias, and discrimination on campus that have really harmful effects. These are all things that can lend themselves to mental health emergencies. And so defining what those situations are. And we find that having a protocol that uses decision trees or flow maps that are really easily visually digested can be very, very helpful. Because if you're in the midst of a mental health emergency with a student athlete, the last thing you want to be doing is reading through 20 pages of text. That would not be helpful. in the moment. And then being very clear about who to contact and how, having those phone numbers be very visible and readily available is important.
I really like that idea, Claudia, of presenting the information visually. And I think, and it's just easier for people. We see a very easy to understand diagram. Yes, you go there. No, you go there. And so that's something that I think we all can work on and improve as well. You talked a little bit about more systemic things, racism and so forth. What's the difference between a mental health emergency action plan, which I think traditionally is seen as for an individual who's going through a crisis? What about a post-crisis action plan? So there's a horrendous incident on campus. There's a killing, or there's a death, or there's an act of God like a world pandemic, which is, we all went through. So how do you differentiate that, and should there be a separate sort of post-crisis intervention, or is that tailor-made based on what the crisis is?
There are certainly campus resources that we've utilized when there's been a student athlete death or other trauma to the student athletes, and I've found those resources to be really valuable. They're available at a moment's notice. They're skilled and trained in this type of debriefing and helping individuals that are going through trauma. And I think having those relationships prior to when the trauma occurs is obviously very important. So that's the real beauty of having these plans in place, is that you've already reached out and created those relationships. So it's really simple to activate the post-crisis management plan to get the people to come that need to help the student athletes and who needs to be at those meetings and that sort of thing. So I think including coaches, including administrators, including all of the people that are touched by the situation, but having that plan already in place means that when it's needed, it's very simple to activate.
I agree, especially with that importance of thinking about the different spheres with whom the athlete interacted. If we're talking, say, about an athlete death, for example, so who did they live with? Who did they have close contact in class with? Who are their athletic teammates and other people in the world of sport, etc. And then thinking about how you can and will support each of those circles. And some of that comes down to athletics being very involved, but also, again, thinking about the fact that the athlete is a student first. And so what sorts of resources are there available from your college health center, if and assuming there is one, because a lot of times college health centers are really prepared and well-versed in supporting different segments of campus after any kind of disaster happens.
And I think what I'm hearing is that let's not just assume that there's a crisis, but the athlete will get over it. That when there are crises, we should really be thinking actively about how to intervene and to go outside of athletics and work with the school counseling centers, the schools themselves, because they may very well have great ideas already. In the second edition, best practices, there was a concept that really wasn't fleshed out very much in the first edition, and that's trauma-informed practices. So maybe, Claudia, help us understand what a trauma-informed practice or care plan means, and then Kim and Claudia, how do we incorporate that into our campus?
Yeah, it's a great question. And trauma-informed care is a concept that has gotten appropriate increased traction in recent years, and goes back, at least in part, to research on adverse childhood experiences, ACEs as they're called, in the early 2010s, which some big studies that helped us really appreciate how impactful trauma is in people's lives and how it affects the way they seek and support and accept or not healthcare as adults, mental health care, general medical care, and what their experience of that is. If you have a history of trauma, it's harder to trust healthcare professionals. And we as healthcare professionals do not want to re-traumatize individuals who have suffered previous traumas. And so that's what trauma-informed care is all about, establishing safety for our student athlete patients and making sure we're not doing things that usually unintentionally may re-traumatize them. And so that means things like, how are we giving them an active voice in their care? So we're not taking an authoritative stance where we're telling them what they must do, but actually we're getting their buy-in and we're giving them options, and we're being transparent, and we're providing them appropriate confidentiality when warranted as well.
And I think this
Yes,
is really interesting, Brian, in sort of partnership with developing a plan, is that you also have to be flexible with that individual and what they can engage with, correct? Like it isn't always that I have this plan and this is where they need to go and this is what needs to happen. The patient really needs to be directing their care and know what and get to make choices. So I think sometimes when we have plans, we sort of insist that our plan be exactly prescriptively followed. And with some patients, I think we have to be more nuanced and flexible about how and where do they want to seek their care and what kind of care are they really ready to accept.
Yeah, that's a great point, Kim. And it's really an important point that we sometimes miss in electronically dictated medical records. I mean, we are clinicians, and our care sometimes needs to be nuanced and really personalized. You know, in the last segment, we talked a little bit about reentry. So someone has a mental health condition, they need to take time off, or they've had a severe injury and they have a prolonged time off. But with that, we've been assessing their mental health. But, you know, we kind of have an idea of how to develop reentry programs for ACL repair or an ankle sprain or rotator cuff surgery. But what about for mental health conditions? Maybe let's start with you, Claudia. How do you develop reentry plans, or is that still way before science and we're kind of just winging it?
Oh no, we need to be talking about this now, even if we are a bit, before science. And I think your point is well taken that for general medical or surgical situations, there are more well-established protocols where we can do strength testing or range of motion testing or whatever it is. And there's this sense of more of an objective marker for when the athlete would be ready to return to play. But in mental health, it's not quite at that same objective level necessarily. But I like to think of three big factors in terms of if I'm trying to help with the decision of clearance to return to practice and participation: functionality, safety, and stability. Dr. Carla Edwards is a psychiatrist who I really admire, who wrote a really transformative paper on mental health readiness and return to play. And she describes those three factors quite well. So in terms of functionality, is the student athlete who's returning from a mental health situation functioning in the rest of their life adequately? Are they able to go to classes? Are they able to do regular self-cares? Because if they're not able to do the other things in their life, how can we expect that they are going to add on the large commitment that is sport and be able to function with that added burden as well? So there needs to be this basic place of functionality. Safety is number two. Is it safe for the athlete to return to sport? And one of the things I always ask myself there is, what role did sport have in their mental health condition? Was sport worsening or even causing their mental health condition, or was sport actually helpful? It served as an antidepressant or in whatever other way it helped. If though, for example, the problem was a severe eating disorder, and sport was a big precipitating factor of that, then you have to take care that it's actually safe to return to this thing that may have exacerbated their mental health condition. And then finally, the third thing, stability. Are they at a place of improving? Are they on the up and up? Are their mental health symptoms getting better? Or are the symptoms plateauing at a low place or continuing to deteriorate. Because returning to sport, if symptoms are severe and not getting better, well, that may be a setup for not a successful return to sport.
I'm wondering, Claudia, do you think we could develop a return to sport protocol like we have for concussion? And it's based on functionality, safety, and stability. I mean, I love that concept.
I think that would be a wonderful idea. Yes.
Right. Well, let's maybe, I know the co-chairs of the IOC consensus meeting, the second one on mental health and elite athletes. Maybe that could be added to the agenda.
I'll make note of that. Thanks.
Well, that was great. How do we maybe, Kim, can you talk again, getting a bit granular at the campus level? How do we continue, and Claudia mentioned continuous improvement, and that I think that means an awareness as well. How do we continue to keep the education and awareness of our action plans really front and center on campus? What are some tips you have for our schools?
It's really challenging to do this, but I think it's well worth the effort, and that is to have regular communication around how the plans are working or not working, what have been the challenges to implementation, making sure that all the stakeholders are having at least quarterly, but ideally monthly conversations around situations of concern or things that might need to be improved. So there has to, I think anytime you have a activation of an emergency action plan, there needs to be a post-event review to make sure that the plan worked as it was designed. Even on routine referrals, we tend to have, as a staff, conversations around, okay, what's the referral process? How's it functioning? And are there things we need to do? For instance, do we need more resources? Are there athletes that are waiting, weeks to be able to get in with a mental health provider? So I think just quality improvement means having reviews and conversations with stakeholders to make sure that the plans are working.
Yeah, it almost sounds like we just can't talk about it enough, right? I mean, so you just keep bringing it up, and I think the mistakes in the past, like for other aspects of general clinical care, is that we introduce it at the beginning of the season when we're introducing a ton of other stuff. And then that's it. We kind of go on with our routine. So it's finding imaginative ways and maybe even, just sort of descriptive ways that we just have to do this every so often and keep bringing it to everyone's consciousness, because
I think
that's how it's ultimately going to improve.
the structure, I think with athletic training staff, having it be a bullet point on your staff meeting agenda that's always discussed, having a behavioral health management team with different representatives who come together at certain time points to make sure that all things behavioral health, whether it be education, whether it be planning, that those things are being reviewed and discussed and moved forward. And we're not just resting on, okay, we've checked these boxes and now we can go about our day, but keeping those goals in mind of continuous improvement.
And that we really get full coaches buy-in and support for that too. What about rehearsing plans? And let's start with an emergency mental health action plan, because look, hopefully everyone who's listening to this Spotlight edition has fully rehearsed CPR and AED placement. That's sort of like a given. Everyone should be certified in that. How do we rehearse mental health emergency action plans? Maybe Claudia and Kim give us a couple of ideas on that.
I can tell you how a lot of the rehearsing goes on here at my institution, and that is via our mental health first aid training programs. I already mentioned that, but we have many people who participate in these trainings, and then once you're trained in it, many of the members of our athlete entourage become certified instructors, and they continue to participate in that way. So there's a continuous refreshing of the training, and a big part of the training does involve walking through scenarios and using your emergency mental health action plan. And I just can't speak enough to the importance of going through these common scenarios. So the coach who notices cut marks on an athlete's arm, what in the world do you say in that circumstance? I've gotten so many calls, texts, emails, questions about, I noticed this, what do I do? And the words get stuck in their mouth and they don't want to say anything that's going to possibly make it worse. So, you might err on the side of not saying anything, which is problematic in its own right, but understandable. So going through these situations where you give people the words to say, and then how do you connect them with resources? It's just really valuable to walk through those experiences that come up so often.
I 100% agree, Dr. Reardon. There's certainly times when you practice, like Brian had alluded to, where you practice acute cardiac care and other emergent situations. And so in doing that on a basis of with team, staff, coaches, operations directors, people who are touching student athletes. So you can incorporate both of those things, a facilities walkthrough, a mental health action plan review. You can incorporate that into a single event to make sure that those things are being addressed, at least on a preseason basis, so that it's in the front of mind for people.
So this is one of many times now that we have discussed mental health first aid. Again, our very first series. So it seems like that's getting a bit of momentum. And just for all our entire audience out there, if you haven't thought about incorporating mental health first aid into your school, maybe think about it, because it seems to address a lot of concerns, rehearsal, but more importantly, really just getting the awareness out of the importance of mental health across campus and within athletics. So, Kim, how do you even feel the need to rehearse referrals for ankle sprains or ACLs, or is that just so deeply ingrained that you don't need to do that? And how, if that's the case, how do we get mental health in that same place?
Yeah, I think that's a really good point, Brian. I think that what I've found is with younger staff members or people that are new to employment, talking through like scenarios that happen and talking through it as a whole staff, so everyone gains by the experiences that others are having. And that's from the provider perspective, right? But with the student athletes, I think they've for the good, I think, are ahead of all of us. They're much more comfortable today coming and saying, I really need mental health support. I'm really struggling with anxiety. I think it's the providers then that need to have the confidence to know, okay, what is it that I need to do next? What do I do with this information? Or if the coach comes to me and says, did you notice the cut marks on said student athlete, and what should we do about it? I think it's empowering those providers then to be as confident managing those situations as they are the ankle sprain or the ACL injury. So that comes with being confident in your assessment skills, right? I know how to assess an ankle. I know how to assess an ACL. How do I assess someone's current status and know where to refer them appropriately? Because that's what I'm going to do with that torn ACL. I'm not going to just take care of it myself, right? So I think having the people who are triaging and managing, really knowing and feeling confident in what their next steps are and who do they need to involve in this patient's care. And how and when, like that's another. And I think we'd be remiss if we didn't mention that almost every campus has a shortage of mental health providers for what their needs are in terms of their general students, as well as for their student athlete population. So we know that we're all dealing with a real challenge in terms of finding the resources we need. It isn't so easy as just, making that phone call and getting that simple referral set up sometimes, because there may be a wait.
Oh, that's great. Thanks for that, Kim. I think just closing out. So Claudia, you've been a repeat guest here. We had you going way back when we were doing almost the weekly sessions on COVID, and we talked about COVID and mental health, and you've given so generously of your time. Any closing thoughts on how we're bringing all of this together? Our action plans, our awareness, and ultimately all of this is for our most sacred asset, our student athletes. Any parting words from you?
Thank you for the opportunity. I think remembering that our athletes are students first. And so if you have nothing else, in place yet, and this is all overwhelming, starting with those resources that are available for all students at your campus is a really important step that you can take. Then building on the athlete-specific resources from there. And big point number 2, whatever you can do to continue to demystify and destigmatize mental health. Kim's absolutely right. It has destigmatized for our young people, for our athletes at a much faster rate than it has for older populations. But we need to destigmatize and demystify this for everything. So wherever we can be talking about this, disseminating our plans, our protocols, our referral options, all the better.
Yeah, very, very well said. And some of our athletes are moving in a spotlight way more so than they were on the court through NIL deals and so forth. And, remembering, as you said, that they are students, and I think also very importantly, remembering these are emerging adults. They're young adults in many ways, and they're human beings, and they're vulnerable, and they shouldn't be worshipped as gods or goddesses, and understand that we all have our vulnerability. So, look, this has been great for our audience. Just I can't tell you how thankful I am that you're here, and also that Kim and Claudia have shared their valuable time with us. And reach out to us if you feel that we need to give more spotlight series sessions on certain aspects of the mental health best practices, or really on other aspects of clinical care. Let us know your thoughts. But thanks so much for being with us, and looking forward to the next time. Take care.